So moving ahead, we have question answers. We have some question answers. So can Madhav Desai sir ask those questions?
I don't have the, I cannot see the chat.
Yeah. So we have wonderful question to Dr. J.J. Mukherjee sir and even to the Yajnik sir also. The benefits of using GLP-1 agonist in type 1 over type 2. So the question seems to be, okay, what are the benefits of using in type 1 over type 2?
So you're directing it towards who?
Yourself, sir. GLP-1.
Okay. No, I won't recommend using GLP-1 receptor agonist in type 1 diabetes, period, full stop. SGLT2 inhibitors, people are trying. There are some trials, as you know, in the inverted commas. I don't know what's 1.5 diabetes, but I'm told that what I understand is type 2 diabetics, long-standing, who are overweight. In that group, they're thinking of SGLT2. Their trials are going on, but I would 100% again recommend no SGLT2 inhibitor or GLP-1 receptor agonist therapy in type 1 diabetic patients for the audience that I'm talking for today. Full stop.
Thank you, sir. We have another question which shows that in Indian scenario, we have the prick barrier. The prick therapy is always taken as a barrier. One of aspect is cost, which you directly mentioned about. Now the prick barrier comes up to both the topic. If we see the GLP-1 therapy also, or somewhere in the diabetes and pregnancy group, when we are about to initiate the insulin therapy. So to both the legions, what we would like to know about is how the best practices you put in to advocate those pricks to the needed individuals.
Dr. Yajnik, you go first with the insulin.
Yajnik sir, your mic is mute. You have to unmute your mic.
Okay, if pricks are essential, then I don't think there is any controversy. If it's a type 1 diabetes patient who needs to take insulin, he has to take insulin. And we make it much more comfortable. When I started practice or when I was a student, it was glass syringes with needles which were boiled. Many people had these stones on which they used to sharpen it. So that was where we started. Then came disposable syringes, needles, reuse of disposable syringes without boiling, so cutting on the cost. Then came the pens. And then, of course, there are now smart pens, and then there is a pump. So injection has progressively become less painful. And today, I think most of them will use either disposable syringes with fine needles, which are short, very sharp. So pain is more a problem in the observer's eye than the patient's. And all our young children seem to take it very nicely. So proper sort of education, which I think is the hallmark of diabetes treatment, and you guys are all doing it wonderfully well. We also started 30 years ago, education and involving the patients and the family in the treatment makes it all acceptable and easy to do. So I don't think injections are. In pregnancy, a pregnant lady will do practically anything you tell her if you say your baby's outcome are going to be improved. So there's no problem about injection. There are extremely few women who have refused to take insulin in pregnancy when it was indicated. And as you know, the so-called gestational diabetes, which we diagnose today, if you advise them on diet, activity, a little bit of other things, majority of them don't need any pharmacological treatment. They are controlled once they know about it. What we are or I am challenging is, do we really know what we are doing? And that actually is an open question. For those who have high glucose, which was there from beginning, has worsened in pregnancy, we of course treat them with insulin. If you go to US, the current standards of practice for diabetes control, pharmacological diabetes control in pregnancy is insulin. In Europe, people are using various agents starting with metformin. In India, we use metformin and acarbose quite commonly. Now, long-term follow-ups, which is really the bane of all the pregnancy studies, is available in extremely few studies. So MIG study, which used metformin in gestational diabetes, done from Auckland by my friend. Again, long-term follow-up rates are only 30%. They have lost 70% of patients and their children for the follow-up. So that's why I think in a place like India, we have a great opportunity to look at these things carefully. And if you guys are really interested, I would certainly like to organize a multi-center follow-up of women who have been treated for gestational diabetes for their own outcomes, on which we have written quite a bit, and on the outcomes in the children. And my new message today was that it has all been present from before pregnancy. What I missed, maybe I can show you one slide actually, which I missed because your monitor for this was really strict. So she allowed me 24 minutes. So I actually out of 25. So I couldn't show you this slide. If you like to see that, I would just, if you give me the sharing.
Sir, your slides are shared.
Are shared.
Your
Yes,
slides
sir.
are visible, sir. Yeah.
Put it on a slideshow mode. Yes, sir.
So we spoke about high glucose in the girls who are diagnosed as diabetic in pregnancy. Also, boys in our study who have high glucose as young adults, they also had high glucose as children. And both the gametes, namely the sperm and the ova, have faced high glucose and other metabolic abnormalities from earlier life. And as you know, glucose, lipids, and a whole lot of other things that are abnormal in the so-called metabolome have a potential to epigenetically change the genome of the gametes. So they actually come to pregnancy with gametes which are epigenetically loaded. And then majority of pregnancies are not planned. So woman doesn't even know when she is pregnant. She knows only much later. And the epigenetic reprogramming of the zygote happens within 48 to 72 hours of conception. And therefore, to say that I will diagnose gestational diabetes at 24 to 28 weeks, when actually part of the metabolic abnormality was before, I think, again, I'm going to say I'm quite provocative. Provocatively is a big joke. And what you achieve is you introduce an element of intrauterine growth retardation in third trimester. This is okay if your baby is going to be born 3.8 or 4 kg. If your baby average birth weight in India is 2.8 kg. Average birth weight in my gestational diabetes clinic is 2.9 kg. So I think there is a need to sit, look back, and seriously think, okay, what do we actually achieve? Certainly in the long term, we don't seem to be achieving much. In short term, whatever we have achieved by reducing size of baby applies to American obese pregnancies where macrosomia associated problems are very high. If we were to educate our obstetricians, our seizure rate would dramatically drop. And I think we need to seriously think about this. So that's what I would like to say. And I'm not very popular for saying what I'm saying because a very big sickness industry has developed around GDM. Everyone is happy when a GDM is diagnosed because there is something to do. There's something to do for the patient, there's something to do for the doctor, for the ultrasonologist, for the laboratory, for the hospital. We admit them probably when it's not necessary. We deliver them much earlier. So introduce an element of pre-maturity. All that can be avoided if we look at sensibly. And therefore, my plea to you is please go back and start thinking, okay, what we are doing, is it justified when sugar is just 3 milligrams above the cut point or something or something. And given the big market, people have devised various ways of diagnosing it, even if you don't go on to do a full GTT. The largest association between maternal glucose and bad outcomes is with fasting glucose. And in India, we just don't measure fasting glucose because of our criteria. Totally disagree with it. So if you measure fasting glucose, that gives you actually a very good idea. You need to understand what is the distribution, what are the associations, what are the risk factors. It's not that if it is 92 or above, things are wrong. 91 is equally bad. 91 is bad than 89 and 89 is worse than 87. So I think all this philosophy of associations and what outcomes we are trying to control needs to be very seriously reconsidered. Needle and syringe in pregnancy is one issue. And as we discussed, I think a pregnant woman will do it if necessary because she is very interested in the wellness of the baby. Okay, that's it.
Thank you so much. Thank you so much, sir. It was something great to know.